record on this computer. All right, go ahead.
Okay, once again, thank you for inviting me to this presentation. Originally, when we had discussions now about 18 months ago, pre-COVID, I was hoping to be there in person, but the world's changed and we are now in the world of Zoom. So hopefully this will come across as well as I hope it will, I expect. For those who haven't yet seen the presentation, the excellent presentation by Drs. Martin Orbeck and Dr. Jeremy Calais, I think it's 549 on your YouTube channel. They went through a lot of the basics of what I was going to talk about today. So I'm actually going to move on a little bit to give you a bit of a flavour of where the field is going. I'll talk a little bit about what's happened in Australia and a bit in Europe. But really, I think Martin and Jeremy did a great job at introducing this topic a few months ago. And if you haven't had a chance to look at that talk, I would strongly suggest you do. Just going to share my screen. See if this works. You see that okay?
Yes.
Yeah, that's nice.
Excellent. Okay, these are my disclosures. I'm actually the principal investigator in a number of trials, mostly prostate cancer, but also in a number of different cancers.
I said yes.
And just a little bit about Genesis Cares was mentioned. The company started about 12, 13 years ago in Australia, but now, in fact, our largest presence is in the United States as of 2020. We have run around 200 radiation therapy centers around the world. And I think now we're the largest private oncology network globally. In the theranostic space, we've been very busy. We have 5 theranostics facilities in Australia, 1 currently in Windsor, the UK, with the plan for a further few theranostic centres in Australia, the UK, and over the next 2 years, similarly, theranostic centres in the United States. Our centres are usually integrated cancer centres, so you have chemotherapy consultations, high-level imaging with PET, MRI, etc., theranostics, all on one site. And we also integrate our exercise physiology and exercise medicine into our centres. We're strong believers of not only traditional approaches, but the importance of overall well-being for patients to do well, cancer patients to do well. So getting on to PSMA, this was brought up previously by Drs. Orbeck and Calais, but PSMA is an interesting protein that sits on the surface of the prostate cancer cells. And there are multiple binding sites, and you'll see all those letters A, B, C, D, E, F, and G. Well, they're all different sites where different compounds have been made to bind to the PSMA molecule. So when you see various PSMA ligands, that's because there are different ways of actually attaching to that molecule. And I've put down some of them down the bottom there, some that I'm sure you've heard of, such as PSMA11 and of course fluorine PYL, others such as PSMA1007. And similarly, there are agents which are just imaging agents, and then there are agents which are just therapy agents such as 617. And there are also agents which are both imaging and therapy, such as INT. The interest in PSMA has exploded over the last decade, and that's just reflected in the number of publications in the scientific literature that have exploded, particularly over the last 5 years in the interest in PSMA. For those that don't know how we make this, basically there are 2 forms of making at least gallium PSMA. If we want to make fluorine PSMA, then we need a cyclotron, and on your left is the image of a GE cyclotron. And on the right are 3 different generators. So they're constantly making gallium in the generator. Once we make the gallium, we transport it to, in the past, we used to transport it to these big chemistry sets, really. These units that would then attach the gallium to the compound PSMA. Nowadays, it's all been streamlined, and in fact, most of the places in Australia use the gallium PSMA kit, where you just mix it up in a kit and then it's ready almost to administer to patients. So once you make the compound, we perform some quality control. We administer the dose to the patient, and there's a fairly set dose depending on body size. Then we wait somewhere between 30 and 90 minutes for the tracer to distribute. And similarly, the imaging time on the PET camera really is dependent on the size of the patient and the scanner. It has only a 68-minute half-life, so the time is fairly critical. It's difficult to transport gallium PSMA long distances because of that 68-minute half-life. The fluorinated compounds are better because they have a longer half-life, and also you can make a larger quantity of fluorinated compounds currently. It's quite nice that you don't have to be fasted, but we do want patients to be well hydrated. There's no really known interactions that we've seen so far over 10 years with using gallium PSMA. No major side effects have been recorded. I've seen a few cases where patients may have developed a rash with gallium PSMA imaging, but really nothing of any major concern. Some centres will give intravenous fluids, and some centres give diuretics to dilute the urine. We don't routinely do this. Some centres give intravenous contrast, which we do to better visualise the ureters. Some centres also would do a standard contrast CT at the same time. So rather than going and having a contrast CT at a different stage, we'll do it all on one sitting. Some centres do early and delayed imaging, and that's really to get better views of the pelvis and the prostatic bed. And some centres may also get you to empty your bladder after they do the first set of imaging and do another set of imaging then to get a better view of the prostatic bed. The radiation safety precautions are similar to FDG PET. It's a renally excreted substance, so it comes out in the urine. So there's a few precautions, but because of the short half-life, in a few hours, there's virtually very little left in the patient. So it's a very safe agent to use. And this is what a PET camera looks like. I'm sure you've seen them before. And we inject, take images, and 30 minutes later, we can start reporting the scan. So I've gone through most of this. We've used this for about 10 years now around the world. In Australia, it's been used for, we're coming up to the 7th year of use of gallium PSMA. It's been shown, as I think it was well described in the previous talk by Martin Norberg and Jeremy Calais, that it's got high sensitivity, high specificity, high predictive value, and a lot of clinical utility. It's very useful for staging high-grade disease, for radiotherapy planning, for assessing biochemical recurrence following initial therapy, and also for assessing oligometastatic disease. And it's changed the way we practice basically in Australia. We still have more to do. We need more data on if early diagnosis and early treatment actually leads to much better outcomes. We haven't yet got that data, but that data is coming. In Australia, we actually started, gallium PSMA was started at the Wesley Hospital by Dr. David Wong in 2014. Peter McCallum started, I think, a bit later that month in Melbourne. In Perth, we started in 2015. In fact, David Wong taught me how to read gallium PSMA PET scans in early 2015 in Brisbane. F18 PSMA actually entered the Australian market in 2018. And now there are multiple sites offering either gallium PSMA or fluorinated PSMA in Australia. And it's interesting, it's mostly done in the private practices in Australia. And the cost is quite reasonable at between $600 to $1,000 US. This compares to significantly more in the UK. And I've heard of some high prices also in the United States. We did a study early on, just looking at how it compared with CT in diagnosis. And it was shown in our study of over 100 patients that it was significantly better than diagnostic CT in assessing recurrent prostatic cancer. From this, you also see that as your PSA gets lower, our pickup rate drops. So we routinely advise clinicians that try to do a PSMA PET scan when your PSA is less than 0.5. Has a relatively low yield in the literature, somewhere between 25 to 35%. This is a case in primary staging. Patient had a high PSA, high Gleason score on initial presentation. He had standard imaging, which is at the time was a CT pelvis, bone scan, and then went on to the gallium PSMA PET. Now, the CT and the bone scan showed no evidence of disease, but the gallium PSMA PET showed the primary disease in the right lobe of the prostate and the previously undiagnosed focus in the sternum. Now, this was in the early days, and we weren't quite sure if this was true disease. It was biopsied and it was metastatic prostate cancer. This patient was still treated aggressively. He still underwent a prostatectomy, but that focus was treated with SBRT or stereotactic radiotherapy to the sternum, and he did well from that combined approach. PSMA is an interesting molecule. It's associated with prostate cancer aggressiveness. It's actually, there's a reason that we see lots of PSMA on a prostate cancer cell. It needs it for something. A prostate cancer or any cancer doesn't make something unless it really needs it. It's actually critical in a number of pathways, important for cell growth. And it's also been shown to have a prognostic significance. Usually means if you've got lots of PSMA expression, that usually means it's a more aggressive phenotype. It's overexpressed 100 to 1,000-fold in just about all prostate cancer cells, but not 100% of prostate cancer cells. And as I mentioned, it appears to correlate with advanced disease, castrate-resistant disease, Gleason score, and to a degree PSA level. PSMA, for those that don't know, is also not truly prostate cancer specific. It's found in various tumors, and in fact, I'll show you an example. So this is an example of a high-grade cancer. So you can see Gleason 4+5, and you'll see the intense activity in the prostate in this high-grade tumor, and also a nodal deposit in the groin. And one of the things we've also found once using this imaging agent is some of what we were taught in medical school isn't quite correct. We were always taught it's unusual for prostate cancer to spread to inguinal lymph nodes. We now know that it's not that uncommon. And similarly, we've often seen prostate cancer spread to the nodes, the lymph nodes above the neck, with very little in between. And it's really been PSMA PET that's been able to delineate how prostate cancer spreads much better than we ever knew with other forms of imaging. This is a case actually of one of my patients who has anaplastic thyroid cancer, a very aggressive form of thyroid cancer. In fact, when they presented, it was inoperable. That was in August of last year. And you'll see the PSMA expression in the neck is quite intense. This patient actually went on to have radiotherapy, immunotherapy, and actinium PSMA, which I'll briefly mention. And in fact, has become now resectable and had her thyroid cancer, which you can see from the images above, has decreased in size and shows virtually now no increased metabolic activity. She's now had that resected last week. So talking about some of the data which wasn't presented in the previous talks by Olbert and Calais, there was a big impact study performed in Australia at a number of sites, including several Genesis Care sites. This was a multi-center study, and it was really looking at what's the impact of gallium PSMA. And so in over 400 patients, approximately 100 in primary disease and 300 in biochemical recurrence, we found that the addition of PSMA PET changed management in about 1 in 5 patients who presented with primary staging, and in over half the patients who presented with biochemical recurrence. So it had a significant impact in the way we managed these patients. There's another Australian study called the Pro Psna Study, and this was really looking at gallium PSMA in primary staging. In this case, patients were randomized. They either got standard imaging first, which is CT and bone scan, and then went on to gallium PSMA, or they had gallium PSMA first and went on to have CT and bone scan, depending on what the findings, and then they were followed up for 6 months and analysed. And basically what we found was that PSMA PET gave us much more definite answers. So far less equivocal imaging. It also was more likely to change management. It was also safer for the patient because you had less radiation exposure with PSMA PET alone versus CT and bone scan. And so it outperformed our standard staging. In fact, the accuracy was found to be 27% more accurate than our usual staging methods. They've also looked at the cost effectiveness. So they looked at the same data and did a cost effectiveness analysis, which this has only recently been published in December of 2020. And in fact, they found that it's actually cost effective. It actually saves you money to do PSMA PET CT versus your standard staging. So hopefully this will be used for our authorities in Australia to reimburse this, because currently this is not reimbursed in Australia and patients have to pay out of pocket to get this study done. This is a slide from Martin and Jeremy, and I'm not really going to go into the data that they went through. I think they did an excellent job of showing that PSMA PET is actually superior to conventional imaging, not only SPECT, but also some of the agents such as choline and Axion. So I don't intend touching on those topics. As I said, the excellent presentation goes through it in quite a lot of detail. I will tell you, however, what we've seen in Australia. So David Wong, as I mentioned, he was the first guy to bring gallium PSMA to Australia. He looked at what happened to their practice at the Wesley. The Wesley is a very busy prostate oncology practice. And over a 5-year period, the number of bone scans that they did dropped by 95%. So it has a significant impact in places where you use it. People start realizing that the bone scans have limited utility for a lot of prostate cancer. There was discussions in the previous talk by Oberg and Calais about radiotherapy planning, and this is one of the early papers showing that if you use PSMA PET, you change your radiotherapy planning about half of patients. In another study from 2017, they changed the treatment was modified in 77% of radiotherapy patients in this study out of Europe. And in Australia, we basically, I don't think there would be a radiation oncologist in Australia who would consider salvage therapy without getting a PSMA PET scan first. It's really changed the way that they manage prostate cancer patients. In 2018, in Valencia, there was a consensus group who looked at where they believe PSMA PET should be instituted, and this is what came out of the consensus group, that it should be in biochemical recurrence in staging of high-risk prostate cancer for radiotherapy planning. And there were a few areas such as targeted biopsy, surgery, that was still under investigation, or monitoring treatment response, which is still under investigation. Later this year, these will be the proposals which we look forward to the Australian government for reimbursement for PSMA PET based on data accumulated to date, which are very similar. The first 3 are exactly the same as the Valencia consensus. In fact, the first 5, but also the 6th is for assessing suitability of targeted radioligand therapy or theranostics. So using PSMA PET as a companion diagnostic. And this is based on the Australian phase 3 therapy trial, which was a trial of lutetium PSMA versus cabazitaxel chemotherapy, and also the VISION trial data, which ran in the United States and in Europe, and we're hoping to get the results of that later this year. Moving on to where things are going and what we're seeing in Australia. So there's a lot of interest now in using PSMA PET to help better diagnose the prostate cancer. So adding it to MRI, multiparametric MRI of the prostate and initial diagnosis, and maybe also giving us a better idea about where the really aggressive tumor is. And that can also help direct biopsies. And this is one of our patients who we were able to help where the biopsy was directed to try and get a more accurate diagnosis. And we now even have at certain sites in Australia in-bore MRI PSMA-guided targeted prostate biopsy. So based on MRI findings together with PSMA findings, we can go in and do a single or a double pass biopsy rather than the traditional 16 needle truss or truss type biopsy. So this decreases the risk of infection, risk of bleeding and complications by doing targeted biopsies, and you try and go for the most active site in the tumour based on MRI and PSMA. There's also a few groups working on PSMA-guided surgery. So you inject some surgical agents, and there are now some longer-lived surgical agents. There is a technetium PSMA available, which lasts several hours, so you can actually use these probes, either a PET probe or a SPECT probe, and in surgery find lymph nodes and remove them at surgery. So there's quite an interest in that. This is a study that was done out of the Munich group in Germany. And even the companies such as the Da Vinci robotic company are introducing PET probes and SPECT probes into their Da Vinci robotic systems to allow for robotic surgery using the signal from these agents at the time of surgery. So gallium PSMA is very equivalent to the PYL compound, distribution similar, and the studies that have looked at whether one's better than the other really seem to say that they're relatively equivalent. And that's been shown in a number of studies and was also brought up by Drs. Orbeck and Calais in the previous talk from last year. PSMA 1007 is a different compound. It's not excreted in the urine or minimally excreted in the urine, but it is excreted in the liver, or it's metabolized in the liver. We've been using this for about 12 months in a study in my hospital in Perth. It is a very good agent to look at the prostatic bed in early disease recurrence, because you don't have the problems of the bladder. But it is a problem in that we pick up a lot of benign bone lesions. And so we see many more benign bone lesions with PSMA 1007, which is an issue. So moving on from PSMA, I know in the last discussion or the last talk with Orbeck and Calais, there was discussion about what happens if you're PSMA negative. And in fact, there is an agent which we're now starting to do some work on. Novartis also have this compound. It's called bombesin. It is gas-releasing peptide receptor. It's also found on prostate cancer cells and a number of other cancer cells. And in fact, you can use it to detect prostate cancer. But interestingly, there's been a small study where they've looked at patients who are PSMA positive and PSMA negative, and they've sort of found that if you're PSMA negative, you're more likely to be bombesin positive. And so if you're PSMA positive, you're more, more likely to be bombesin negative. So this is an agent which is currently in trial, but it may give us an opportunity for that small group of patients who don't have PSMA expression, where we can use other imaging techniques, and potentially this opens the way to other therapeutic techniques as well. So moving on to theranostics, this is one of the first patients we treated in 2015 with lutetium PSMA. And in Australia, it's not covered unless you're part of a sponsored trial. But we have the opportunity for compassionate use through our compassionate use program. So patients pay for the treatment. It's on a cost recovery. The patient just pay for what it costs us to provide it to the patients. The Veterans Affairs Department, however, have now agreed to pay for lutetium PSMA. The Veterans Affairs in Australia have been paying for gallium PSMA for 5 years, ever since we introduced it. but now they've agreed to also pay for lutetium PSMA in Australia. Interestingly, lutetium PSMA is paid for by private insurance providers in the United Kingdom, as well as in New Zealand. So lutetium PSMA follows the same principle of gallium PSMA. We're looking for a target. If we find that target, we change the type of radiation from an imaging radiation, which is gallium or fluorine, and we change that to a therapeutic radiation, which is either lutetium or actinium. And there are other types of therapeutic radiation moieties which are coming down the line, which I won't go into. It's different to radiotherapy. In radiotherapy, we shoot X-rays or beams of radiotherapy through tissue and hit cancer cells. With radiopharmaceutical therapy, we attach the therapy to the cancer cell, and then the radiation annihilates it from within. So there's less effect on adjacent tissues. And also the type of radiation is very different. Radiotherapy is given in a femtosecond of time. It's a shot over a very short period of time, whereas our type of therapy is emitting constantly and decaying away, sometimes over several weeks. So it's a different flux of energy. And there's a lot of interest in what happens if we combine the two. Will that give us a better outcome? And in fact, we have a study looking at that later this year. So targeted radionuclide therapy has a number of interesting and potentially beneficial attributes. We get direct dose to the tumor. There's minimal toxicity because we don't really affect adjacent tissues. You get specific targeting. You can work out the dose, and we've got a whole group of physicists actively involved in this at the moment, trying to work out best dose to tumor and also minimal dose to other organs such as salivary glands or kidneys, etc. And combination therapy is also where we think this field is heading, and I'll talk a little bit about that as we move on. This is our current standard protocol. You have some imaging, some blood tests. If you're appropriate, you're given 2 cycles of lutetium PSMA and you're monitored in between with blood tests and consultations. After the second cycle, we do some more imaging, we reassess, and then we decide if we're going to change tact or we're going to keep going. Most of the trials have been done within 4 to 6 cycles of therapy. The most cycles I've ever given anyone is 11 cycles over a 5-year period. So you can give more than 4 cycles. The side effects are minimal. It's an outpatient-based therapy. I've listed the most common side effects, which are lethargy, nausea, and if you've got extensive bone disease, you can get a bone flare, and you can get a transient dry mouth, and that usually improves. But the more cycles of lutetium you get, the more damage you cause to the salivary glands. So in the therapy trial, the results were about 10% of patients complained of a mild dry mouth after 4 cycles of therapy, and that seems to be the same in our cohort. This was a therapy trial. So this was a trial that's concluded and is now being analysed, and some initial results are out. And this is a trial looking at lutetium PSMA versus cabazitaxel PSMA in metastatic castrate-resistant prostate cancer. And basically, the summary of it is it's more effective than cabazitaxel, and it's less toxic than cabazitaxel. So they're still waiting on overall survival data. They should have that later this year. And on the basis of this data, once again, there'll be a submission to the government to see whether we can get lutetium PSMA reimbursed instead of cabazitaxel as a second-line therapy. The data that we see from the therapy trial, which was a prospective, well-controlled trial, is very similar to our data that we look at and also other people's cohort data. So this is a study done on around 100 patients, a retrospective study, and their outcomes are very similar. So what we're seeing in the real world setting seems to fit with what's actually been shown in trials. And we're also seeing a few interesting parameters. So we know that if you have bone disease, it seems to be a bit harder to treat. And also if you've got visceral metastasis, which is different to nodal metastasis, that's, for instance, liver metastasis, that's usually a more aggressive form of therapy, of disease. We've reviewed our patients. We've now treated around 400 odd patients across our centres, given over 1,000 cycles of lutetium PSMA, and we have an ongoing data collection, and our results are very similar. Our toxicity is very similar. We've published on the fact that there's very minimal renal toxicity, and also we published on hematological toxicity with our colleagues at Oxford. There's been some interesting work on whether this treatment may be of benefit in the pre-taxane setting. And if you look at retrospective data, the results seem to be a little bit better if you give it before chemotherapy. However, it hasn't been tested in a prospective trial, though there is a trial. There are 2 trials coming up, one by Novartis, actually both by Novartis, that are going to look at whether you should be given lutetium PSMA prior to chemotherapy. We've looked at it in different stages of disease. This is a paper we published with some European colleagues showing that, in fact, if you have lymph node predominant disease, then you actually have a very good response to this therapy. And so we've seen prolonged remission rates of up to 3 years if you have lymph node only disease with no bone metastasis. And so if you look at our survival curves compared to a paper by Hoffman in a cohort of patients with end-stage disease, you'll see that lutetium PSMA in nodal-only disease, and one would presume that to be earlier stage disease, seems to have a much better effect. So similarly, there's an interest in how good can this be? How good will the therapy be if we give it earlier? There was a discussion at the last talk by Albert and Clay about PSMA PET and can use SUVs to determine whether that's the best way of determining how things will go with therapy. We use an automated artificial intelligence program based on MIM software, which allows us to get a lot of information so we can work out a mean SUV for the whole body tumour volume. And we've had a look at what are the imaging predictors of response to radioligand therapy. And interestingly, the only one that's really come up as a predictor is total tumour volume. SUVs have actually not come up as a predictor. This was presented at the World Molecular Imaging Conference late last year. So these are a series of trials in Australia. The Vision trial, the one in red, sort of in the middle, was not performed in Australia. It was performed in the US and Europe. But these are a whole series of trials, and some of them are really looking at bringing in lutetium early on. So we have the ENZAPI trial, which is looking at does the addition of enzalutamide plus lutetium give an advantage. There has been some data that the androgen receptor blockers like enzalutamide may increase PSMA expression, and so that's being looked at in a prospective fashion by my colleague, Professor Louise Emmett. That's a multi-centre trial. There's a trial in Australia looking at the addition of docetaxel chemotherapy to lutetium PSMA. Will that improve outcomes? And there's also a very early trial giving a shot of lutetium PSMA prior to surgery in high-risk patients to see if we can almost sterilise the surgical field. So these are some of the trials. There's a trial right at the top called the Lupin trial, which I'll talk briefly about. That's using a radiosensitizer called Vionda or idrinoxin to try and potentiate the effect of lutetium PSMA. Early data suggests it does, and in fact, we've started to introduce that as in a compassionate access program. We've been doing that now for about 18 months. And there's also the PRINCE trial looking at immunotherapy plus lutetium PSMA. And there's also another trial looking at PARP inhibitors plus lutetium PSMA. So there's a whole series of trials being done across Australia and now also across the globe. So the Lupin trial, interestingly, is the same as the vision trial in some ways. It was up to 6 cycles, but they gave the Yonder, this radiosensitizer. It was a single arm trial, but they showed much better response rates in a similar population as the vision trial than we have traditionally seen. So an increase of sort of 10 to 15% on what was initially seen, and that's very encouraging. They saw a similar response also with external beam radiotherapy, and that's called the DART trial. I thought I'd present a case and give you a bit of a flavour of how we approach things and the way we work and the way things are going. So this is a gentleman, 79-year-old retired lawyer, who had been treated with standard therapies, including 2 cycles of chemotherapy. He even had strontium therapy. And he basically had come out of there was no other treatment option. So he was referred to us in September of 2017 with a fairly rapid rise in PSA and oncologists who basically had run out of treatment options. He was a very active man and his question to me was, will I see Christmas? We treated him, we first of all did a PSMA PET. He had widespread bone marrow metastasis, liver, lung, and nodal metastasis. His doubling time was, about 4 weeks, and the question was, will lutetium work when you've got such aggressive disease? But he was keen to try it, and he had a great response. His PSA plummeted, his blood counts were normal, essentially normal. He ended up having a second cycle. And then we did a PSMA PET after his second cycle as our standard protocol. And he had resolution of his liver, lung, and nodal metastasis, but he had bone disease which persisted, which is not uncommon. We decided to monitor him for three months, and his PSA then started rising. And over the 3 months, from January 2018 to May 2018, and I apologise, we've got the dates in Australian order rather than US order. But over those 4 months, you can see his disease progressed quite dramatically. So he had widespread disease. We then did what is going to be looked at in the Enzapi trial. We added enzalutamide to the lutetium, and he got an excellent response. So that's on some data out of Europe showing that the AR blockers increase they upregulate PSMA expression, particularly in the castrate-resistant setting. And once again, if we look at his imaging from May to August, had an excellent response to the therapy of enzalutamide plus lutetium PSMA. So we then gave him a further 2 cycles, and his disease, his PSA did not sort of drop any further. It was sort of stable and then started rising, but we got into his second Christmas at home, which he was very happy about. And then we repeated his imaging in December, and we started to see some recurrence of the disease. His PSA started rising. By February, it was up to 2,000. So we then decided to try capecitabine, which is also a radiosensitizer. It's used very much so in neuroendocrine tumors. So in Australia, we would not give lutetium dotatate, which is a standard therapy now, without at least capecitabine on board. It's also been used in prostate cancer, though with variable results, but it really had no effect. And in fact, his disease was progressing on the PSMA PET scan. We also started doing FDG PET. And the reason for that is to make sure he didn't have what we call discordant disease that had no PSMA receptors that we weren't picking up. And in fact, he had concordant disease. All the disease we could see was more avid on PSMA than FDG. And so he should still be appropriate for PSMA targeted therapy. His PSA started rising, his hemoglobin started falling. So we went on to actinium PSMA. And he was given a few cycles of actinium PSMA. He had a really good response to his first cycle. Then his PSA started rising again, and he had virtually no response or minimal response at all to his second cycle. And these are his PSMA PET scans over that period of time. We once again looked to make sure he didn't have discordant disease, which he didn't. And then we went on and decided to give him actinium PSMA, now this time with Vyonda, Idrinoxal, the radiosensitizer. And he had a dramatic response. His PSA initially jumped, and we see that quite often. You may get a jump after PSMA, and that's probably cell death and a spill of PSA into the blood. And then his PSA dropped to about 5,000 from around 10,000. This was now to October, and he'd been battling this disease for many years, and he'd been battling, and he'd been treated with us for a period of time. Also, unfortunately, the actinium PSMA had destroyed his salivary glands. And his marrow was now starting to feel the effects of all this treatment. And he decided against further treatment. He decided he wanted to pull out, and he succumbed just before Christmas of the third year. So over 2 years, he'd received 7 cycles of lutetium PSMA and 3 cycles of actinium PSMA. We'd seen no renal toxicity at all over those years, and we only really saw hematologic toxicity at the end. He was very grateful, however, he was able to travel. At that time, he could actually get on a plane, and he traveled extensively, and he was basically symptom-free until late October 2019. So that's the sort of approach that we have moved into over the last 5.5 years of using this. I thought it would just be an interesting scenario so that you get an idea of how we actually manage the patients. And we work very closely with our radiation oncology colleagues and our medical oncologists. So we've now got over 2 years experience with actinium PSMA and also beyond that. And we've worked out groups where we think you should go straight to actinium, and also how we manage patients who are not doing well on lutetium PSMA. We've also now moved more to molecular diagnostics and considering things like PARP inhibitors if you have particular mutational analyses. And as I've mentioned, with the use of AR blockers, it's quite interesting. We've had patients who failed AR blockers, but after lutetium, in fact, they are seem to be resensitized to androgen receptor blockers. So we'll get more of that information, of course, from the NCP trial. So just finally, this is an area that has taken the interest of major pharma. Over $10 billion have been spent in mergers and acquisitions over the last few years by Novartis and other large companies. Novartis have decided that this is an area of primary focus for them. They've got a whole series of agents coming out, not just in prostate cancer, but in other cancers. And they're also wanting to bring the therapy into earlier stages of disease in prostate cancer. Clarity Pharmaceutical, they're out of Sydney. They've got prostate cancer as well as other cancer agents, and we're doing some trials with them in the prostate cancer space. Telix Pharmaceuticals out of Melbourne, similarly, have got a number of agents. They've got a very interesting agent, which we're about to start a trial on. That's J591. And it's interesting in that it's an antibody, not a peptide. And it doesn't bind to the salivary glands. So there is no salivary gland toxicity with this agent. And just finalizing, at ASTRO, which is the large radiation oncology meeting held in the United States every year, in 2019, there was a prediction that by 2035, 60% of all radiotherapy given around the world will actually be this molecular targeted radiotherapy. It'll be theranostics. So there's a huge amount of interest in prostate cancer and other cancers. And hopefully I've given you a bit of a feel of what we're doing, the way the field's going. But it's a very exciting time in this area and a good time for patients. And we believe that this sort of approach, the theranostic approach, will end up being the sixth pillar of cancer care after surgery, radiotherapy, chemotherapy, precision therapy, and immunotherapy. And on that note, I'll say thank you, and I'll open it up for questions.
Okay, thank you very much, Doctor, for an outstanding presentation. Does anybody have any questions for the doctor that you want to put in chat? Probably put in the chat. It's going to be your easiest bet since we have so many people here tonight.
Neil, I'm going to remind anyone that wants to ask a question, hit the space bar or unmute yourself on your screen.
Well, that's a great idea. Yeah, make sure You push down your space bar as you talk if you're going to address directly. If not, put it up in chat and then I will read the questions. Once again, are there any questions for the doctor? Please unmute yourself by pressing down on the space bar and ask in person. Why don't we try that? Oh, here we go. Here comes the questions. This is from Dr. Charles Metzger. Can you say more about the genetic findings in non-responders to these therapies?
Yeah, thanks. That's a very good question. At the moment, it looks as though some of these patients have moved on to a more aggressive form of neuroendocrine type transformation, small cell type transformation. And in fact, we've done a bit of work in doing somatostatin receptor imaging in that group of patients. And you can, in fact, if they've got sufficient somatostatin receptors, flip around and use agents such as lutetium dotatate, which is currently used predominantly in neuroendocrine tumors. So we do know that in end-stage prostate cancer, I think the guys at Stanford have shown us that up to potentially a quarter of those patients have moved on to small cell type transformation. We also know that there seems to be a group of patients who have got BRCA mutations who may be less responsive to lutetium PSMA. Of course, they seem to have a response to PARP inhibitors, but it's not well documented yet. There hasn't been a number of good trials, though all the new trials that are coming online are starting to look at it in a prospective fashion. And similarly, the trials that we're getting involved in, we're very interested in the molecular profile to try and determine which patients, in fact, would benefit the most from lutetium PSMA. FDG PET is used quite a lot to try and work out whether patients should have lutetium PSMA, because if you've got lots of discordant disease, which usually means a more aggressive phenotype, then your outcomes are probably going to be worse. And in fact, there's been a few small trials that have shown that. But it's an area of interest to us and many people.
Okay. In fact, we have a lutetium question. Would you ever recommend lutetium for a recurrence in a hard-to-treat area like the nodes near the spine or heart or the semical vessels after radiation?
Yeah, that's a good question. So we do that routinely. One of the good things about lutetium is that it doesn't really damage the areas adjacent to it. And we've had a number of patients who can't have any more radiotherapy to an area. They've reached their maximum tolerated dose where you can give lutetium therapy. In fact, I've got a few patients where it's been difficult in that they've got small volume disease, but in an area that's been previously aggressively treated. So they're stuck with a recurrent disease in a small area where we can give lutetium. Now, the thing about lutetium is it's very good at controlling disease, but it's not that good at totally eradicating disease. So I don't think we've actually ever cured anyone with lutetium. We've been able to put them into remission and sometimes prolonged remissions, but I don't believe we cure them. And that's something that I would have to tell someone if they had recurrence in a node, for instance, in the pelvis that had been previously radiated. I'd say, look, if there's PSMA expression, the higher it is, the more likely we will respond. But there's a good chance at some point in time it will recur.
Okay. Chuck asks, how hard is it to set up if you are from the USA for PSMA? I think what Chuck is asking is, how do I get treatment with PSMA? How do I get treatment here in the USA, or do I have to go to Australia?
Yeah, so from a treatment point of view, we have a different regulatory environment in Australia. We have what's called the Compassionate Special Access Scheme. So when patients are are either failed standard options, or the standard options are not suitable or not felt to be appropriate, they can have unapproved therapies. It's not just for lutetium, they can have multiple different drugs and so forth. There's a number of drugs which are approved, for instance, in the United States, which are not approved in Australia, but we can get access to them through this special access scheme. Currently in the United States, the FDA has to approve a treatment, though you do have, in the last few years, I believe, the Right to Try Act was passed, which is similar, I believe, to our special access scheme, though I'm not sure if anyone's used that piece of legislation to allow compassionate therapy. But I'm hoping that once the VISION trial is reported, that lutetium PSMA therapy will roll out very quickly throughout a number of centres in the United States. And I know Genesis Care are keen for that to occur.
Okay. A question from Bruce. I had a radical prostatectomy 31 months ago. My final Gleason 7 disease confined to well within the prostate margins. My PSA was undetectable until July 2020 and has now risen to 0.263. Is it too soon for gallium-68, for PSMA-11, for PET, for CT?
Yeah, so that's a good question. We look at a number of different parameters. Just on the number alone, 0.263, we would basically say, based on our data, the chances that we'll pick anything up is probably going to be about 20%, 10 to 20%. But that's when you look at all patients. So if someone has a high Gleason score at the time of initial presentation, then you may pick something up a bit earlier, because you may postulate that their metastasis or their local recurrence is of a higher grade. If the PSA doubling time is fast, so if someone's PSA doubling time is, for instance, 12 months, it's probably a very low-grade indolent process, and it's unlikely we will see that with PSMA PET at that level. But if the PSA doubling time is more like 2 months, then that suggests a much more aggressive phenotype. And once again, in that situation, we may consider a PSMA PET. So we look at a number of different parameters before we say yes or no, it may not be of use. And similarly, the most likely site of recurrence will be likely in the prostatic bed, or maybe within a small lymph node in the pelvis. And we do have issues with PSMA-11, and that's where I think an agent like PSMA-1007 may be of better use, though it's not widely available. So that's the way we approach it. I'm not sure if that answers the question.
Okay, and Bruce, if it doesn't answer your question, please resubmit. Here's a question from Dr. Metzger. How successful have you been with the surgical probe?
The surgical probe is, it's really a one-off. We don't use it routinely. There are surgeons who are quite au fait with surgical probes. We have some surgeons, particularly in Melbourne, who I don't actually work with them, but they're at the Peter MacCallum and they're very keen and they're looking at it. But I don't think we've got enough data yet to say whether it's a useful approach. I think it's more of an occasional specific case scenario rather than routine use. But I'm not a surgeon, and at the moment we only use it in isolated specific cases. Okay,
how would you compare PSMA effectiveness to a therapy using choline-11, particularly with a patient has a low PSA level?
Is that imaging or is that therapy?
Chuck, do you want to clarify here? Is that imaging or is it therapy or imaging? You can press your space bar down if you want to talk.
Yeah, no, I was thinking of the imaging primarily.
Yeah, look, choline, we did some studies on choline back in the, I'm trying to think when that was now, early 2000s. And there have been a number of studies now, particularly in Europe. Choline's not routinely used in Australia. It was routinely used in Europe, and I don't think there's any site now in Europe who was using choline that hasn't shifted to PSMA PET. So I think by and large, PSMA PET is more sensitive. There are a few isolated cases where choline may see something that PSMA PET doesn't, but that's few and far between for most patients.
Thank you.
Are there, a question from Larry, are there tests you can perform to determine the effectiveness of the therapy prior to going forward with the therapy? If so, what is the correlation between a positive test and a successful therapy?
Yeah, so look, the only test really that may have some benefit, well, the two tests are PSMA scan. Like if you've got very low uptake, SUVs less than 5, then you haven't got a lot of receptors for us to target. So we know that you may have an effect, but it won't be that effective. The higher the PSMA expression, theoretically more of our agent should go there, and so it should be more effective. And also FDG PET, if you've got what we call discordant disease, so disease which is hot on FDG PET but is not seen on PSMA, then that's a different phenotype. That's an aggressive phenotype, and it's a phenotype that we won't get any treatment to. So that means that even though our therapy may work on some of your disease, it definitely won't work on all of the disease. And that means that the disease we are treating will just continue to progress. Those are the only two at the moment, but we're hoping in the future we will be able to do a biopsy or possibly even a blood test. So for instance, in neuroendocrine tumor, we now have a blood test which can predict whether lutetium dotatate will work in neuroendocrine tumors. That's through a company, a spin-off of Yale called Ren Laboratories. And I know that they're working on a prostate test to do the same sort of thing.
Going on to Maury, how would this treatment be possible for a sclerotic lesion around the spinal cord in one vertebrae? I guess what Maury's looking for is, what are my treatment options because I have a sclerotic lesion around the spinal cord on just one vertebrae?
Yeah, so look, the standard for us is for oligometastatic disease, which is one lesion, then radiotherapy is usually the way to go, occasionally surgical treatment. If patients have already had radiotherapy, then we would sometimes consider it. But you've got to remember, we're giving a whole body radiation dose, a lot of radiation throughout the body just to hit one little spot. So wherever there's only one side of disease, we'd always try and go for a local therapy. But more importantly, often sclerosis is associated with the disease becoming potentially quiescent. Often when we treat cancer in a bone, it will become sclerotic. But it is important to know, is it sclerotic and dead, or is it sclerotic and still alive? And that's where PSMA PET would be useful, because if the PSMA was negative and it was a sclerotic lesion, then you may postulate that it's not actually active.
Here's from Lawrence. One frequently sees a number of, or 25% for successful treatment with lutetium-177 and PSMA-617. What does successful treatment mean? Complete remission must be very rare.
Lawrence is completely correct. Complete remission is rare. So the standard for treatment response is, as was mentioned by Jeremy and Mun in the last talk, is the sort of standard, the surrogate standard is if we see a drop in PSA by greater than 50%, that suggests that we've got rid of a lot of tumor volume, and we would hope that will correlate to improvements in what we call progression-free survival or remission, and hopefully also improvements in overall survival. So it means that you would actually live longer having the lutetia PSMA. Now, when we look at other drugs, sometimes you may be shocked to hear what overall survival rates are for chemotherapy, for instance. They're often measured in months. So even though it's a successful treatment, we don't have a lot of therapies, particularly in metastatic disease, that will lead to a cure. More often than not, we're trying to aim for remission and improvement in symptoms. So I think one of the benefits of these type of therapies is that so far from what we've seen, they're at least as effective, if not more effective than our current standard reimbursed options with less side effects. And they can improve symptoms. So we have patients who, for instance, have pain, who can get these therapies and have a period of remission where they'll be pain-free. So that's where these therapies are benefit. But you're quite right. We don't cure people with a metastatic disease. We can try and get the disease under control for as long as possible.
Okay. Bruce has a question. Is there any new data available on the therapy trial? I see he's put down RPFS or OS since ACSO last summer.
No, Bruce, we expect it any week now. I heard it was going to be released in March. It might be released. We have our Australian New Zealand scientific meeting in April. So Michael Hoffman may present it there in April, but we are expecting. One of the issues with overall survival data, which is quite interesting, is that the longer it takes a company to release it, usually means it's a good thing because they're waiting for a certain number of events to occur. And if events aren't occurring, then that's good. So a delay usually means an improvement in overall survival, if you sort of understand where I'm coming from.
Okay. Are there any additional questions that anybody would like, or would they like a follow-up on a question that they've already asked?
Neil, let's make sure the doctor needs to go at 8:30. So
okay,
we got 20 minutes. Is that correct still, doctor?
Yeah. I've got to get to clinic.
Okay. If there are no more questions, I just wanted to quickly introduce everybody of the Prostate Forum. Dave Lehman is our Chief Technical Officer and our Chief Financial Officer. He's at the controls. Ira Caggett's down here. He is our expert on newly diagnosed. Jim Bothwell joins us. He's one of our newest members to the Board of Directors as our treasurer. And I see Larry down here somewhere, Larry Barman, who communicates with our presenters, and Maury Hartman, who has wonderfully handled our advanced diagnosis support group now for many, many years. I'm Neil Burke. I am the Chief Executive Officer, as well as Vice President of External Affairs. If there are no other questions, having kind of introduced anybody, I might just let us go on with our evening.
So Neil, can you hear me?
Yes.
Yeah. I'm going to ask the doctor one question here. What is the cure rate for oligometastatic prostate cancer?
That's a really good question. It's not an area that we are greatly involved in, because it's usually in the area of radiotherapy, actually. And I've seen some results, and it depends also on the number of lesions. So they sort of break it down to 1 to 3 or 3 to 5 and greater than 5. I think the cure rates, if it's greater than 5, are not very great. But I've seen results of 5-year sort of remission rates of over 80%, even over 85% in small oligometastatic disease based on PSMA PET. So that means 1 to 3 lesions. And there's been 2 trials, an American trial and a European trial, which have shown the benefit of radiotherapy in those situations. As I said, it's not something that we do much of with lutetium therapy. In fact, if I see someone with one metastasis only, or two metastases, I would refer them on to my radiation oncology colleagues.
Thank you, Doctor.
Can we help anyone else tonight with a question?
Mr. Weaver, were you over there in Australia?
Lawrence, press your space bar down so you can talk.
Okay, can you hear me now?
Oh, I can hear you.
Yes, sir, I was. I just made a comment that, yeah, I made 3 trips over there, had 3 cycles of lutetium from Dr. Nat Lenzo in Sydney. And that if anyone is curious about going and so on, that I would be willing to talk to them and share my experiences and tell them a little bit how to go about it.
Thank you, Larry.
Larry, I know you have a question to share here. I had lutetium 177 PSMA 617 treatment, 3 cycles from Dr. Lenzo in 2018, 2019. Any questions? My contact info is lweaver746@gmail.com. You can find that in the chat if you don't have the chat box open right now.
How are you, Lawrence? Nice to see you.
I am generally feeling pretty much okay. I've gone on Zytiga and ADT. The ADT Firmagon, I had 2 gallium scans before I started. This was after I had the lutetium. I was on it for 6 months, the Firmagon. The disease advanced on all fronts. The ADT did not work, absolutely did not work. So then they added Zytiga. Zytiga seems to be working well on the visceral lesions, but not on the bone lesions. My bone lesions have continued to increase. I've had 16 bone lesions treated with proton therapy so far, and my disease consists of 33 sites that I'm following with the gallium-68 PSMA scan. So PSA, by the way, is 1.20. So 1.20 nanograms per milliliter sure doesn't match 33 cancer sites. So yeah. I suspect that my cancer does not make PSMA anymore to speak of.
Yeah, look, and has anyone done a biopsy to see if you have any mutational targets such as BRCA?
I just completed the Foundation 1
yes.
Liquid biopsy CDX, yeah. And it mentioned TP53 and also BRCA2 plus some others. But so far, none of my oncologists have gotten back with me to say, well, what can they do with that? Are there any treatments or what, you know?
I would suggest seeing your oncologist, particularly if you've got a BRCA mutation. It does open up certain possibilities and may also explain the difficulty in getting your disease under control. But anyway, I wish you all the best, Lawrence, and it's really nice to see you.
Oh, well, thank you for the suggestion. I'll follow it up.
Anyone else? If you want to unmute your space bar and get a follow-up on your question, please do. Next month, February 25th, from 7 p.m. to 8:30 p.m., Dr. Justin Human of Tower Urology Group, Cedars-Sinai Medical Center, West Hollywood, will join us. The topic will be male health, incontinence, erectile dysfunction, and testosterone management. By all means, watch. If you have subscribed to our emails via Constant Contact, you will get a Zoom link on this. If you haven't subscribed, please subscribe to us at prostateforumoc@gmail.com, and we will gladly sign you up on our constant contact list. We don't abuse it. There's basically meeting announcements that go out on that list, and a few community events like the Prostate Cancer Research Institute conference, which is 3 days here in Los Angeles, California. A very interesting conference. I hope we have COVID-19 under control to an extent we can meet in person for that conference in September. Anybody else want a question before I close the meeting or comment? You're also welcome to send your comments to us. If you think there's something that we can improve on, please contact us at prostateforumoc@gmail.com. Dave, how do you feel about closing the meeting? Do you think we're in a good place?
Let's just thank the doctor, and it's 11:30 his time, I believe. So he's still got a day of work. So thank you,
Thank you
Doctor.
very much, Doctor. We hope to do this again with you real soon.
Yeah, look, and if you've got my email address, if you have any questions, by all means, send them. Happy to reply.
Lawrence just adds, I will be starting Regulux I hope I totally missed next week. I totally mispronounced.
It's Orgovix is another name for it. That's the trademark name.
I'm sorry, I totally mispronounced that.
I don't get it right either. For those who may not know, it is a daily tablet substitute for either Firmagon or Lupron injections. And it's supposed to have some distinct advantages. When you start it with 3 tablets, you don't get a flare like you do with Lupron unless you take Casodex. If you go off of it, you stop taking it, your testosterone returns to normal within a few days. It's supposed to have less cardiac effects. It's supposed to work better than Lupron, in fact, in lowering your testosterone. They're offering 2 months free supply that they send to your house, which is a pretty good deal. I don't have any feel yet for what it's going to cost after the 2 months, but I'm prepared to have an arm or a leg amputated just to try the drug.
Well, Lawrence, we wish you luck with that. We wish everybody luck with their journey with prostate cancer. If we can help anybody else with a question. Very good. Dave, I'm comfortable closing the meeting if you are.
Yes. So thanks for being here, and I'll get it posted probably tomorrow night. There's processing before I can get it to the YouTube. So thank you.
Thank you all very much, and hope to see you on February 25th, 7 p.m. Pacific Standard Time.
Thank you, Doctor.
Thank you very much.